Welcome to the National SBIRT Brief Intervention and Referral to Treatment, ATTC, Webinar Wednesday. Today our topic is SBIRT for Adolescents, and we have Dr. Sharon Levy from Harvard Medical School and the Boston Children's Hospital as the presenter. Dr. Levy, I'll transfer this over to you now.
So while that's happening, I also just want to thank you for inviting me and thank the audience for agreeing to spend an entire afternoon hearing me talk about my favorite topic, which is screening and brief intervention for adolescents. The poll results were very encouraging because it seems like the large majority of people are practicing in organizations that are either using SBIRT or they could envision using SBIRT, and yet a lot of people aren't doing it themselves. So hopefully this webinar will be really helpful in thinking about how you might incorporate some SBIRT practices into what you're already doing. So with that in mind, I want to say this is a fairly long session, and I've broken it into three pieces. The first is about the neurobiology and the specific impact of marijuana and alcohol use on the developing adolescent brain. After that, we'll take a brief break for questions. I'll move to an overview of screening and brief intervention and demonstrate some of the simpler techniques that will be used for kids who have either not initiated substance use or who have initiated substance use but haven't really fallen into the high-risk category yet. And then the last hour will be on, we'll do a brief run-through of motivational interviewing, which probably most of the audience is more expert on than I, but I want to focus on how we can put those kinds of tools into brief interventions that are really practical within the context of ongoing care. So that's the structure of the session, and there we go. So here are the objectives of the entire program, and that is that we want to demonstrate the orderly progression of neurodevelopment, review studies that demonstrate the toxic effects of alcohol and marijuana on the adolescent brain, some of the findings in general. We'll move on to talking about the epidemiology of adolescent substance use with short and long-term consequences. I'm going to demonstrate a screening and we'll call it a screening and brief intervention algorithm that can aid clinicians in quickly and accurately assessing risk and choosing the appropriate intervention. We'll then move on to defining motivational interviewing, demonstrating techniques, and an approach to a brief motivational intervention that's practical in a general setting. I want to start with this slide. So as you are probably aware, our ability to do neuroimaging and really understand what's going on in the teen brain has been advancing over the past couple of decades. We can now get these really exquisitely detailed pictures like the one you're seeing on the screen. But seriously, I do want to start with an overview of brain development. So we know that the brain grows throughout childhood. And in the first 3 to 5 years of childhood, the brain grows very, very rapidly. And basically that growth involves the production of new cells and new connections between cells. So those are the parts of the brain that we call the gray matter. And in early childhood, the gray matter is very rapidly growing and developing, and particularly in the limbic system and the cortical neurons. And if you don't know what those areas of the brain are, we'll talk about them in just a minute. And associated with that rapid growth is actually a tremendous increase in the weight of the brain. And what is actually surprising is that if you're looking only by weight, brain growth appears to be complete by about age 10 or 12. So this is a graph that shows age across the x-axis and brain weight on the y-axis. And you can see here, I hope you can see the cursor, but by about age 10 or 12, that's about as big as the brain's going to get. Now, before we had sophisticated neuroimaging and other ways of looking at a living brain, the only way we could really study the brain was doing postmortems and really just weighing brains. So for a long time, a long, long time, people actually thought that brain development was pretty complete by about age 12. Now, those of us who take care of children or have children of our own or once were children know that somehow that doesn't seem quite right. There is certainly a difference between a 12-year-old and a full adult, and it's only been more recent that we're starting to understand what some of those differences are. This is a cartoon that was specifically drawn for this slide presentation, and the artist writes here, "Don't you gross anatomy me, young lady. You can't go drinking until you're mature on a cellular level." So what's really going on? So in adolescence, although the brain size doesn't change much in terms of its weight, what is going on is that the amount of gray matter is actually decreasing. Okay, so we're getting apoptosis or planned neuron death in certain areas, as well as pruning of excess connections. And at the same time, we're getting this fatty material wrap the connections that do stay around. And the reason that they're being wrapped in fat is because that's insulating them. And neurons communicate through these electrical impulses, and the myelination is the same idea as insulating an electric cord that you might use in an appliance at home. It's increasing the speed of transmission. Okay, and so this is a picture of microscopic picture of what the brain looks like at birth on the left. At 6 years old, when the brain has about as many connections as it's going to have, and then what happens by 14 years old. And this picture is really important. It's surprising to some people that brain tissue, neuron tissue, seems to max out at about 6 years. Well, this state here in the middle for the 6-year-old, this state really is the best state for learning. It turns out that having a lot of connections between cells really enhances our ability to learn things. And we've all heard, well, if you want to learn a language, you got to start early because you're much more receptive to new words, new grammatical patterns, new kinds of skills in general, not just language, but all kinds of skills when you're this age than when you get older and you have less connections to work with. So why do we do all this pruning? Well, it turns out that this state is much more proficient. So there are far fewer connections, but the connections that we do have are more accurate and faster. And so that's a difference that we can really understand behaviorally, one between a state in which we're really primed for learning and a state in which we're really proficient at something. Now, it turns out that development of, that cycle of apoptosis and pruning of neuron extensions followed by myelination doesn't happen all at the same time in every area of the brain. It actually happens in a very orderly progression. So this is a picture showing how the brain matures. So these green areas are immature brain and the blue areas are mature brain, and you can see that happens over time. And also, you may notice that the pattern is that development happens from front to back. And by the way, this development it completely correlates with behavioral patterns that we see, right? So we know in the first year of life what's really developing is the brain stem and the cerebellum, particularly the cerebellum, and that's the area of the brain that's important for motor control, and we know that that's exactly the time when kids are learning to walk. And the same is true with other areas as well. And you may also notice on this graph that at age 20, there are still a not insignificant number of green areas on this brain, and that's because brain development really continues well into the 20s and is really complete somewhere in the mid-20s. Okay, this is a schematic of a picture of the brain that we took from the NIDA website. And it's showing you two important features that are going to come up a couple of times in this presentation. So the first is the nucleus accumbens, and this is an area of the brain that's involved in pleasure and reward. It's an old area of the brain, meaning that our Much simpler animals will also have it preserved. So it's a very important area of the brain. This is showing you the prefrontal cortex, and this is the part of the brain that's responsible for what we call executive functions, and those are things like impulse control and the things that really help us make good decisions. In some ways, you can think of the nucleus accumbens as a gas pedal, and the prefrontal cortex as the brakes, right? Because the nucleus accumbens is what helps us seek rewards. That's incredibly important for our survival. It helps us seek food and water and mate. And the prefrontal cortex just stops us from jumping in with our feet first and prevents us from making mistakes. It just slows us down. And these areas, of course, are connected. This is trying to show you that the prefrontal cortex actually has connections down to the nucleus accumbens. So in this slide, we've just overlaid where various psychoactive substances will have their impact on the brain. What's really interesting here is that what we're trying to show you schematically is that each substance will have its own particular footprint on how it impacts the brain, and it'll have different areas of the brain in which its effects are predominant. However, all of them will have an impact on the nucleus accumbens, and that's really where the sense of pleasure from drug use comes from, and that's also highly involved in the development of addiction. So this is a slide that's showing you the development of the nucleus accumbens over here in red, as opposed to the prefrontal cortex. Now, if you remember 2 slides back, said you could think of the nucleus accumbens, it's the reward center. You can think of it as the gas pedal in terms of behavior. And you can see that the gas pedal is fully mature fairly early in adolescence. And the gray pedal would represent the prefrontal cortex, responsible for executive functions that you can think of as the brake pedal. And that doesn't really get fully mature until many, many years later in adulthood. So this really, just by looking at this graph, you can understand that there's going to be a natural drive in adolescence to take chances. And this is probably, so now I'm drifting off into speculation, but this is probably was important a million years ago for the survival of the species. We needed our adolescents, I suspect, to go hunt large animals, and it's hard to get people with fully functioning brakes to do that. And so, this may be one reason why we see this asymmetry, why we evolved that way. And there's more to it than just asymmetry. There's also differential response in the reward center at different times in life. So this slide is very complicated, but I think it makes a really important point. This is the results of a study in which investigators would put people of different ages into a scanner. They would give them a simple task to do, and once they successfully completed it, they would give them a reward. Now, on the left, the investigators gave participants a small reward. And so you can see that here in blue, they looked at the response of children upon receiving the small reward. And you can see in this gray area that children's brains were quite activated. And these were very small rewards, something like a sticker, right? So basically, the kid did a small task. The investor came in and said, great job, here's a sticker. And the kids got very excited about that. And, you may know, if you counsel families, that we often recommend things like sticker charts for young children to help modify behavior. Now, in the green, we see what happens with adults, and basically they did the task, and they got their very small reward, and basically there's a very small blip in their brain in response to that reward. So basically, while young children will great, that's great, I got a sticker, they'll get all excited. Adults will sort of politely say thank you and will move on with their lives. But here's what's really interesting. The black line represents adolescents aged 13 to 17. So they performed the same task and got the same small reward. And here, their brains actually deactivated. This horizontal line is actually baseline activity. They actually turned their reward center off. So again, just kind of put this in the behavioral context, this is like the adolescent who says to you, oh, that's lame, right? They are really not appreciating small rewards at all. In fact, they're a little irritated by them. Come over here on the right, same experiment, except this time the participants got a large reward. For the children here in blue, it made almost no difference whether they got a small reward or a large reward. Their brains seem to be equally excited. This is why I'm a developmental behavioral pediatrician, and I'll tell you, this is why we recommend stickers for rewards for young children. It doesn't seem to matter if you give them a sticker or a pony in terms of what their brain will do. Adults in green are the only rational ones. They make small responses for small rewards, large responses for large rewards, as you might predict as a logical kind of conclusion. Now look what happens to adolescents. As opposed to the deactivation with a small reward, they get this tremendous spike in activity with a large reward. And so you can see that there's this natural drive for them to look for these large rewards and to take enormous chances. And so it's not surprising, and we'll talk about this more in the next session, that adolescence and young adulthood is exactly the time where people are most likely to try and use drugs and other substances. They're also much more likely to do things like binge drink. And it turns out that that's actually predictable based on their neurobiology. So the developing adolescent brain is especially vulnerable to the habit-forming effects of alcohol and drugs. And also of interest is that the age of onset of alcohol or marijuana use is inversely correlated with the risk for developing a substance use disorder later in life. And here's that data. There's been a number of studies actually now showing this in alcohol, but this is data originally published by Ralph Hinkson in 2006. And he found that kids who were really early initiators of alcohol, shown here in blue, by age 13, they had a 47% chance of developing alcoholism. So nearly 1 in 2 of them would develop an alcohol use disorder. And you can see that if people who delayed into late adolescence, early adulthood, the risk fell dramatically. 3 to 5 times. The same pattern was true for marijuana. The early initiators were 3 or 4 times more likely to have a marijuana use disorder as compared to late initiators. So this is really important. Speaking to kids about drugs and alcohol is different than speaking to adults about it. And it's not just because these substances are illegal. It's because they have really long-term, they have both short and long-term health risks associated with them. And in fact, substance use by adolescents is, I would argue, a very significant health problem. Now I want to move on to talk specifically about marijuana and other cannabinoids. Okay, so starting with marijuana, marijuana is a plant that contains many chemicals that are called cannabinoids that are active in the human body. It turns out that there are at least 108 of these cannabinoids that have been identified. But the primary one that we hear a lot about is delta-9 tetrahydrocannabinol, which is, seems to be the most psychoactive and responsible for the euphoria associated with marijuana use. That's often called THC, and that's how I'm going to refer to it in the next couple of slides. You may have also heard about cannabidiol, and this, in fact, may counteract some of the effects of delta-9 tetrahydrocannabinol, or THC. It does not seem to be responsible for psychogenic effects and may have very different properties. And that's something of interest to people who are interested in using cannabinoids medically. I just want to show you this slide. This is from a study that was published in the British Journal of Pharmacology, just really looking at the levels of THC in marijuana. This is marijuana seized on the street over time. So in 1994, the average seized marijuana plant had about a 4% THC content. Actually, in 1970, it was about 1%. In 1994, it was about 4%. In 2008, it was about 9%, and now it's in the 12 to 13% range. And so this continues to climb because breeders are selecting plants with the high THC content. It gives a more powerful, more potent high, particularly for somebody who's developed tolerance. And so it's, as a street drug, it's preferred by users over time. But it's also much more powerful. It is just really not the same drug that people were using in the 60s and 70s. And I'll show you what the consequences of that are. I'd also like to add here that as the THC content goes up, the cannabidiol concentration actually falls simultaneously. So it's really not just that there's more THC, there's a disruption in the balance of how these chemicals are appearing in the plant. This is a picture on the left, on the right in purple of marijuana, of THC, of the active component of marijuana. And on the left, you have a picture of a molecule called anandamide. That is an endocannabinoid. In other words, that is a molecule that your body makes specifically to bind to the cannabinoid receptors on your brain. So that's part of your brain and your body's signaling structure are these cannabinoids. It turns out that THC looks enough like anandamide that it can bind to the same receptor. So basically, THC is mimicking anandamide, but there are some differences. So this is what the cannabinoids do. They bind to receptors. There are at least two types of cannabinoid receptors, CB1 and CB2. CB1 is the one you find mostly in the central nervous system in the brain. When cannabinoid is bound to that receptor, it prevents the release of a number of different neurotransmitters from the cell terminal. Now, these neurotransmitters are how cells communicate with one another. And so basically what it's doing is it's quieting down the activity and the messaging when a cannabinoid is bound to that receptor. Okay. Now, these cannabinoid receptors are found quite densely throughout the brain in many, many areas. This is a schematic with showing you in pink areas of high density of cannabinoid receptors. You can see that they're pretty dense. They're very dense here in the nucleus accumbens. What you'll also see is that there aren't any, or hardly any, in the brainstem. And that's a good thing because the brainstem is responsible for autonomic activity in your body, like breathing and heartbeat. And this is where we can get into a lot of trouble. So because with other drugs, for example, there are a lot of opioid receptors in this area of the brain, and so opioid overdose is associated with respiratory problems and people stopping breathing. Marijuana won't do that because there are hardly any receptors there, but they are scattered throughout the brain, and they do have a number of different homeostatic effects that are very important. So the endocannabinoid system in general has two important roles. The first is regulation, okay? And so we're talking here about sort of the volume of a neuron's firing. So remember that I showed you that when the cannabinoid is bound to its receptor, it prevents release of neurotransmitters, and it basically dials down or reduces the volume, if you will, of a neuron's activity when it gets too strong. This is really important for homeostasis. And what's so interesting about the cannabinoids is that it's not that it regulates so many different neurotransmitters, and it affects so many different systems, including pleasure, mood, pain, appetite, sleep, motivation, focus, memory, attention, and others via a number of different neurotransmitters. And it also, and these neurotransmitters are really present in order to keep your body in homeostasis. A lot of our metabolic energy is spent doing exactly that, ensuring that our body remains in balance, neither underactive nor overactive. The endocannabinoid system has a second important function in the body, and that is guiding growth. So the cannabinoids are there to shape brain development by guiding neurons to grow to the right places and the right targets for brain function. And not only for making sure that those neuron projections get to the right cells, but also that those correct growths are then myelinated or insulated. These receptors are critically important, particularly when the areas for the areas in the brain that are growing and developing, which, remember, is going to happen throughout adolescence and into young adulthood. So THC looks a lot like anandamide, and it binds to the same receptor. Both of them dial down neuron activity in order to block neurotransmitter release. But there is a difference, and that is THC actually has a much stronger and longer-acting effect than anandamide. So it's actually much more powerful at that receptor than our own endocannabinoid. Not only is it much stronger, but when you use marijuana, really, especially nowadays as the concentration of THC has gotten higher and higher, so not only is it stronger, but there's also going to be lots more of it around. And what happens is that when somebody exposes themselves or is exposed to marijuana, the body starts decreasing production of anandamide because it from your brain's perspective, there's already a lot of anandamide in the system. It doesn't need to make more. And so that prevents your body from regulating its own homeostasis, right? You can no longer do the functions that anandamide is supposed to do, and that is in part why it's so hard for people who have become chronic marijuana users to stop, because they're missing this important chemical which helps them regulate themselves, and frankly, they feel lousy. It's also true that with chronic substance use, there are changes in the brain. So so remember that the cannabinoids have this inhibitory effect, and basically chronic use is actually going to result in too much excitation of the brain, which can lead to excitotoxicity and even cell damage and cell death. This changes the brain's chemistry, and it interferes with our homeostasis, our ability to regulate mood and feel pleasure. And in particular, the cells that use dopamine as their prominent neurotransmitter are especially sensitive to damage. And so what happens over time is that you get this reward deficiency with chronic exposure to marijuana. Once you stop the marijuana, it's very hard for people to feel just the normal reward in response to things that are supposed to be rewarding in our environment, such as food, water, and other pleasurable activities. Marijuana also has an effect on memory. The hippocampus is an area in the brain that's particularly important for the memory formation, and lots of different substances, including marijuana, have an impact there. With chronic marijuana exposure, these neuron connections involved in memory can be lost due to continual suppression, and that means that people who are chronically exposed to marijuana will not learn as well as a result of it. And brain imaging studies have shown that people who use THC regularly have smaller hippocampuses, and functionally they have poorer memory, not surprisingly. This is a study that was done in New Zealand and published about a year ago in the Proceedings of the National Academy of Sciences. And what the investigators did was they surveyed over 1,000 people. They started recruiting kids at age 13 years, and then they followed them over time. So they went back and they interviewed them when they were 18, 21, 32, and then again 38. They asked them a whole battery of questions, including a lot of details about marijuana use, and their findings were impressive. So overall, their major finding was that there was a change in IQ between age 13 and 38 years old in people who used marijuana heavily over long periods of time. So if you look here, starting at the bottom, the bottom group were people who never used marijuana. And you can see that their IQ does not statistically change over time. So from age 13 to 18, I'm sorry, from age 13 to 38, their average IQ goes from 99.8 to 100.6. These changes are not significant. Now you can see that the bars get longer and longer as we go up, and here we're looking at people who were marijuana dependent 3 or more years during the 13 to 38-year-old age group. And you could see that these individuals had significant drops in their IQ. So the mean IQ here dropped from 99.7 to 93.9 over time. So that's a loss of about 6 IQ points. And these differences were statistically significant. And if you're, IQ is one of those things, it's hard to know on a functional level what that sort of loss will mean. This would be probably hard to detect, on a functional level, although it does seem to indicate that there's something really neurotoxic going on here when there's heavy marijuana use during adolescence. In addition to that, in this study, and I don't have a slide on this, but the researchers also did do some sort of functional analysis and found that people in the heavy marijuana smoking categories of 3 or more years of dependence actually did have decreases in memory and poorer educational outcomes. So this is looking at IQ change by age when marijuana dependence started. And again, we're looking for the biggest difference in bars. And it turns out that the earlier that marijuana use starts, the bigger the differences will be, and these are statistically significant. And this is looking at IQ change by age when weekly use began among those who have quit by age 38, okay? And so if you start smoking in your adolescence, later in your adolescence, after age 18 and quit by 38, there's really no change, no statistically significant change in mean IQs in that group. But if you look at the people who started smoking before age 18 and then quit by age 38, you could see there is still this decline. So just because you quit when you're an adult, that's not enough. If you were using as an adolescent, you're still susceptible to these declines. This slide is taking a look at pictures of the white matter structure differences between marijuana users and non-users, and you can see, I'm sorry, the circle looks like it's in the wrong place, but you can see there's a real thinning here in the daily user compared to the non-user. And these differences are similar to white matter structural abnormalities that have been found in the brains of schizophrenics. And so that's also a cause for concern because we know that regular marijuana use during adolescence has been found to increase the risk of developing psychosis, schizophrenia, about 6 times. This says 2 to 5 times. It also includes anxiety and depression, but psychosis has been most strongly linked with marijuana use during adolescence, and the current estimates based on a recent meta-analysis are about 6 times increase. So this study is reporting the results of a large longitudinal study of a male cohort. I believe these were from the Swedish Army. There are about 45,000 individuals involved, and they found that of people who they called heavy cannabis users, in other words, who had used more than 50 times by the time they were about 18 years old, they were more than 6 times more likely to develop schizoaffective disorder later in life. So again, talking about the link between schizophrenia and psychotic disorders. Anxiety disorders have also been linked to heavy marijuana use. So adolescents who use cannabis daily were 2.5 times more likely to have an anxiety disorder when we controlled for other things like socioeconomic status, alcohol use, other substance use, and depression. And heavy cannabis users during adolescence also had increased rates of anxiety disorders at age 29, even if they quit in adulthood. So the key here is that marijuana use, heavy marijuana exposure or heavy THC exposure during adolescence seems to do some damage that looks like it may not be reversible even when individuals quit later on. Depression has also been linked with heavy marijuana use, and in this study, both those with early onset, less than 15, and adults onset greater than 18, moderate cannabis use increased their risk for depression by about 70 or 80%. Okay. I am actually going to move along to alcohol at this point, and then take a break for questions after this section. So alcohol is quite different from marijuana, unlike THC, which binds to a specific receptor, and that's where it has all its effects in the brain and in the body. Alcohol is a small molecule that can easily cross the lipid membranes of cells, and it has effects both on the cell surface as well as direct effects inside the cells. Its predominant effect is to increase a molecule that we call GABA. That's an inhibitory molecule that decreases an excitatory molecule that we call glutamate. So the overall effect of alcohol is actually inhibitory, right? Even though it's increasing GABA, it's actually decreasing neurotransmission in the brain because it's functionally decreasing the excitatory neurotransmitter. I know that's confusing. You have to think about that for a second to really get it. And so what does that do? Well, it causes people to relax. It will cause them to be drowsy with high enough levels of alcohol in their blood, and it can cause them to become unconscious as the blood alcohol level increases. It relaxes inhibitions, and that's something that many people enjoy, and that's one reason that people use alcohol, because again, it's inhibiting an excitatory neurotransmitter. It will also slow reflexes and reaction time. We all know that people are lousy drivers when they have some alcohol in them. At high doses, it'll slur speech and reduces motor coordination, and can also impair memory formation. This is a schematic picture of the brain. The blue part here is the hippocampus that we talked about before. Similar to marijuana, alcohol is particularly toxic to the hippocampus. And as you may recall, the hippocampus is part of the limbic system that plays an important role in memory, learning, and emotion. This is a graph showing you the average size of hippocampus in teens. On the right, we have healthy control teens who do not have alcohol use. And on the left, we have teens who have been heavy drinkers or have an alcohol use disorder. And you can see that the means are significantly different, and actually this turns out on statistical testing to be a difference. Now I want to show you a study that was done by Susan Tapert, who is out at the University of California in San Diego. And what she did was she put people in a scanner and she had them do a very simple task where they had to look for a specific shape that was a target. Every time they saw the shape, they had to push a button. And is really looking at simple attention and also spatial working memory. And so she put 16-year-olds in the scanner and she had them do that test. And she compared non-drinkers to heavy drinkers. And what she found was that non-drinkers and heavy drinkers performed about the same on that test. But when she looked at their brains, she saw a pretty striking difference. Here is the 16-year-old non-drinker. And you can see that this person is using relatively less brain to get that job done compared to the heavy drinker who's got to activate lots more areas of the brain to perform as well. So think about this as lifting weights. Somebody who's not very strong may be able to lift a weight that's very heavy, but they're going to have to recruit all kinds of muscles and all kinds of parts of their body to do it. It won't be easy for them, and that's exactly what's happening here when we compare non-drinkers to heavy drinkers. Now, we flash forward to age 20, and we see quite a different picture. Here's a non-drinker at age 20 compared to a heavy drinker, and here we see that the picture actually looks like it's reversed. Well, what happens here is that non-drinkers by age 20 are outperforming the heavy drinkers who've been drinking 5 or more years. And you see that what seems to be happening is the heavy drinkers are no longer able to recruit as much of that brain as they need to perform well on the task. And so this is the point where we're actually seeing functional impairment. Although we know the impairment has already started here, we're really seeing it as functional outcome after many years of heavy drinking. So adolescents with a history of heavy alcohol use compared to non-drinking peers have reduced hippocampal volume as much as 10 to 35%, reduced activity during memory tasks, and these effects may be permanent. And here's my elephant who says, yeah, you heard me. I said I'm drinking to forget. I want to now shift gears just a little bit and talk about the behavioral effects of alcohol on the adolescent rat. There are certain studies you just can't do in people, and so we have scientists have developed rat models to look at some of these behaviors, and they've come up with some pretty interesting findings. You know, the overall conclusion of a lot of this work is that the adolescent rats are less sensitive to the motor impairing effects of alcohol, while they are as sensitive to the coordination impairing effects of alcohol when you compare them to adults. So basically, when adults get some alcohol in them, they get very sleepy and tired and they go to sleep, whereas adolescents with similar blood alcohol concentrations will actually become motorically activated even though they are impaired. Okay, so here's an example of how one of those studies was done. This is called the water maze test, and basically what you do is you take a rat, you put him in a tank of water with with platforms where he can climb out. It turns out rats don't really like water, so as soon as they can, they swim over to one of these platforms and get themselves up into the air. Now, what was done in this study is adult rats were compared to adolescents, and we looked at two different things. One was how fast they were swimming. So it turns out that, as predicted, adult rats, when they get some alcohol in them, they swim much slower compared to rats who haven't had alcohol, or actually these are the same individuals before they had alcohol. When you look at adolescents, you don't see that kind of motoric impairment. They can swim just as fast with alcohol on board as before they had any alcohol. However, when we look at functional activity, we saw how fast that they would reach the target. So adult rats, again, when they had alcohol on board, they were much slower to reach that target and get out onto that little platform compared to before they had alcohol. Adolescent rats, even though they were swimming very fast, they were very slow to reach the target. So they were quite impaired, even though they were able to continue with motor activity. And so if we extrapolate to humans, and I realize that there's a big jump there, although I think behaviorally, you know, lots of us have the sense that, well, we know that the common pattern in adolescent drinking is heavy binge drinking, and there's also a sense that adolescents are able to stay more active with higher blood alcohol concentrations, and that means that they're more likely to take risks, like drive a car or go for a swim or engage in sexual activity. And it suggests that we cannot equate adolescent drinking with adult drinking, which, you know, I think many of us may be otherwise tempted to do. And, you know, that's a mistake because their bodies are different, their brains are different, and they don't respond to alcohol in the same way. So in summary, we know that the effects of alcohol on adolescents are that there can be hippocampal damage, and that affects memory, which will lead to lower school performance and job performance over time. And we also know these memory changes are associated with addiction, and adolescents are particularly sensitive to developing addiction. There's increased social stimulation, which a lot of adolescents like. There's increased physical activation, which is potentially problematic because it's associated at the same time with decreased coordination. So in summary, adolescents are not small adults. Their brains are developing rapidly, and that leaves them susceptible to both the acute and chronic effects of alcohol and drug use. And we just need to be mindful of that when we talk to adolescents. And I hope this presentation gives you the sense that anything that we can do to delay or reduce substance use by adolescents will be to their benefit. Even if we can reduce it or we can delay the onset by a couple of years, it can have a major functional impact and improve outcomes. And I think I'm actually going to stop at this point and ask if there are any questions about the material that I've presented so far.
Thank you. No, I don't have any questions about the content yet, but people are really anxious to get these slides. So I have responded to some, and just so everybody knows, I will be putting the slides on our www.ireta.org webinar library right after this session, so you'll be able to download them then. And the recorded webinar will be on there either later today or tomorrow morning, so they'll be able to view it again then too. I'll type in the website in the chat box as well. So that's it. Thank you.
So do we want to give people just a couple of minutes in case some questions come up, or should I go right to the next section and save more time at the end?
Well, let's see. Actually, one question did just come in. Can you define excitotoxicity? It looks like it's E-X-C-I-T-I-T-O-X-T-I-C-I-T-Y.
Right, excitotoxicity.
Yes.
Basically, that's referring to this phenomenon where overexcitation of a neuron can lead to neuron damage or neuron death. That's really what that means.
That's the only question. Then you can go on, and if people have any questions or comments, we'll take them at the next break.
Okay, good. Well, this must be a very astute audience, because that must have been perfectly clear, which I'm thrilled about. But if questions do come up, again, I'll stop at the end of this section as well. So I hope that the first presentation in this webinar has really gotten people to understand at a very basic level how important it is to try to prevent, delay, reduce substance use by adolescents. And now I want to shift gears to talk about some clinical tools that have been developed to help clinicians talk to adolescents with the goal of doing just that. Now, of course, I'm talking about screening, brief intervention, and referral to treatment, otherwise known as SBIRT. And I'm going to start this one with a case. This is the story of James. He's a 17-year-old boy with no past medical or psychiatric history who comes in for his annual physical. And he's well known to the practice. He's a B+ student finishing 11th grade. He lives with his parents, and he's an only child. He's a 2-sport varsity athlete, so he's really doing very well. He reports occasional drinking with friends on the weekends, but he denies ever using illicit drugs, and he is starting to look at colleges. So after taking a history like this, the clinician is not particularly concerned, and he basically gives James the meningococcal vaccine and a tetanus booster, and he congratulates him on his hard work and at school and his safe choice about drugs. She's chosen not to use. And here is the epilogue. 1 week later, James attends an end of the school year party with some high school friends. While driving home, his car jumps the curb and he slams head-on into a tree. So he had been driving while impaired. He's pronounced dead at the scene, and his blood alcohol concentration at autopsy is 0.24. I'm sorry to start with such a morbid case. And I'm also sorry to report that I think that these kinds of stories happen every day around the country. And the question is, how can we do a better job? Is there anything in James's history which really seems so typical, so unconcerning? Is there anything that we could have done that might have made any difference? The learning objectives of this session are to review the epidemiology of adolescent substance use and both the short and long-term consequences. Of course, we've just reviewed a lot of the physiologic underpinnings of these consequences. We want to demonstrate a screening and assessment algorithm that aids clinicians in quickly and accurately assessing risk associated with substance use to hopefully take the guesswork out of some of this stuff, and to demonstrate the use of very brief interventions to prevent, stop, or reduce substance use by teens. So this chart shows the leading causes of mortality in the 10 to 24-year-old age group in the United States. you can see that the top 4 causes are motor vehicle crashes and other unintentional injuries, homicides and suicides. That leads to 3/4 of all deaths in this age group. And we know that each of these 4 is associated with alcohol and other drug use, and they are all entirely preventable. Here's a slide just to back up my previous point. You can see that in the 15 to 20-year-old age group, the percent of fatalities in car crashes involving a driver under the influence is 21%. This number would actually be much higher if it included marijuana and other drugs, and also if we included non-fatal crashes where people were seriously injured. You can see that this is a huge burden on the public health of adolescents in this country. This is a list of substances used by 12th graders reported in 2011 on the Monitoring the Future study. And I just want to point out that alcohol use, by the time you're in 12th grade, reporting use having used alcohol is very, very common. 2011, 70% of 12th graders said that they had used alcohol in their lifetime. So in some ways, this is a developmental norm, and in that lots of kids will do it. It doesn't mean it's healthy or it's good, but it is common. And so, this is precisely why we need to develop screening tools to sort this 70% into those who have really high risk associated with use versus those who don't, and make the appropriate level of intervention. Now, I also want to point out that past 30 days is the typical definition of current use, and you can look at, even though drinking is very common, 70%, current drinking is much less common, only 40%. So less than half of 12th graders will be current drinkers, even though some may have tried it beforehand. And the same is true with ever having been drunk. Just over half of high school seniors said that they had been drunk in their lifetime, but only 1/4 have been drunk recently. And so anytime you're dealing with a kid who's currently using alcohol or currently reporting having been drunk, you're actually dealing with somebody who is automatically in a slightly higher risk category. Same is true of marijuana. Although nearly half will have tried it in their lifetime by 12th grade, less than 1/4 are current users. And obviously with other drugs, the numbers are much lower, although I should point out that you can look at the numbers of prescription drugs, after alcohol and marijuana, the prescription misuse of prescription medications is very high, and as a class, they come in as number 3. So this is a list, this is some data, again, from the Youth Risk Behavior Survey, which is a nationwide survey that asks questions of kids who are in school. It's very similar to Monitoring the Future. And, I look at this slide every once in a while because I find the numbers astounding. In the past 30 days, 39% of high school kids reported drinking on the survey, and 22% reported heavy drinking. 8% drove after drinking, and nearly 1/4 rode with a driver who had been drinking. So these numbers are very high, and frankly, that's not surprising based on the data that I showed you in the initial session. Adolescents are wired to seek stimulation, to do dangerous things, to look for big rewards, and they really don't have the brakes to slow them down and say, hey, wait, maybe this isn't a good idea. Or at least they're not internal, right? And so part of our job is to see if there's anything that we can impose on adolescents to help them develop those brakes or think a little bit before they engage in some of these behaviors. So I don't need to go through this in detail. This is just a list of the correlates of substance use during adolescence, and we know about these, right? This is injuries and emergency room visits and arrests, sexual assault, and school failure and violence, and all of these terrible outcomes are all associated with substance use during the adolescent years. So we know this. I think as providers, nobody's surprised by any of this. And I think that there's been a real change, I think largely due to SAMHSA's efforts to push screening and brief intervention. Many of us, I would say, across the country have become aware of the importance of doing screening, and I think attitudes are changing. There have been some surveys of pediatricians, one done in 1997, where only 40% of pediatricians said they were screening teens annually for substance use. That number, in a survey that asked similar questions done in 2007 in Massachusetts, that number was over 85%. That's a huge change in attitudes, and I think that's good news. We're all starting to recognize the importance of screening and talking about substance use and trying to prevent it as part of what we do in medical care. Now, that's the good news. The bad news is that when we that we're not yet there in terms of how we're doing the screening. So in the survey that I just mentioned in 2007, where over 85% of respondents told us that they were screening annually, when we asked them how they were screening, they basically told us they were screening on their clinical instincts. And it turns out that this is not a good way to screen. This is a survey that was done by one of my colleagues here at Children's Hospital, and what she found is that she asked medical providers to give their impression of whether an adolescent was using drugs, had any problem associated with that use, had a substance use disorder, or had dependence or a substance addiction. And she compared their responses to a criterion standard, which was a psychodiagnostic interview, which was administered for another study in the waiting room. And what she found was, generally speaking, the overall sensitivity wasn't terrible. 63% of the time that the kids reported substance use, the providers knew about it. So most of the time when kids are using, providers knew, and that wasn't a terrible sensitivity. But you can see it really falls off dramatically So from there, only 14% of the time that a kid had a problem did the provider detect it. That falls to 10% for detecting a disorder and 0% for detecting dependence. So even though we may be okay at knowing when a kid's using drugs, it's very hard for us to assess the risk associated with it, the severity of it. And again, since 70% of kids are using alcohol, another 45% are using marijuana, we really need some quick and easy ways of sorting these kids out. Otherwise, we're going to really miss important opportunities. And so screening is critically important. It's part of both of these algorithms that are typically used in pediatrics. This is the HEADS, or some people call it the SHADES, and it's a psychodiagnostic interview that's recommended for primary care with adolescents. Both of them include D for drugs. Screening is a very important part of it, and it's important to screen with a validated tool that's going to accurately help us distinguish between low and high risk. Now, I'm just going to take a brief pause for a word about confidentiality before I go on with screening. So one of the keys to doing good screening is to make sure you have the right level of confidentiality. So the American Academy of Pediatrics and the National Institute on Alcoholism and Alcohol Abuse both agree that when that you should interview adolescents for sensitive health questions. That should be done without parents present. It's generally okay to keep information confidential unless there's a safety risk. What constitutes a safety risk is really a matter of clinical judgment, and I think it will vary depending on the child's age and the specific behaviors and what else you know about the child. There are some state guidelines that that vary state by state that give guidance on when confidentiality must be broken, and those usually involve threats of domestic violence or child abuse and neglect. And there are some situations in which it's probably a good idea to break confidentiality, and I'll be talking more about those in the third session today. When that does need to happen, I would strongly recommend that you discuss it with the adolescent before you do it. Try out the words to use. and certainly avoid giving, including too much detail. It's important when you are going to break confidentiality, really just to give the main point and tell parents or other adults what they need to know while trying to protect privacy as much as possible. Again, confidentiality is a very big topic that could certainly fill a 3-hour webinar on its own. I won't go into it in too much detail today, but we'll give a little bit more detail in the third session on how it can be done when it needs to be. So now back to our regularly scheduled program. This is an algorithm that we developed here as part of the training tool for our residents in the materials we developed for the SAMHSA-funded project on screening and brief intervention. One thing that we heard from our residents early on in the project was, we really need an algorithm to guide us so that we can flip these decision tools right into our primary care. And so we developed this algorithm. And it looks a little complicated on the slide, but you will have access to these slides if you want them. Basically, it's pretty straightforward. You want to do a little bit of screening. And there are different ways to do that. I'm going to show you 2 different tools, both of which have been recommended by the American Academy of Pediatrics. When the screen's negative, I would still recommend that you talk about riding with an impaired driver. We know that happens in 25% of kids. Reports that they've done that in the past 30 days. We know that driving is the #1, driving while impaired is the #1 threat, mortality threat to adolescents. So, I think it's worth some time, even in kids with no use, just talking about safe riding. And for kids who don't use, we still want to do an intervention. We want to give positive reinforcement. It turns out this is really important because unlike adults, when you talk to a middle-aged adult who's a non-drug user or low-risk alcohol user, there's not really much of a trajectory. It's very unlikely that that adult will cross over into developing a drug addiction or an alcohol use problem. However, with kids, the story is a little different. When you're talking to a 12 or 13-year-old who doesn't have any past year substance use, they are still in a high-risk category for initiating over the next couple of years. And so, again, our job, I would say, is to delay as much as possible, try to delay that initiation. Those who screen positive, those who do report past year use need to be screened to separate into low and high risk groups. Those who are using but are in the low risk group, they need an intervention. We need to recommend that they stop using, frankly. But this also needs to be done quickly. I mean, to be realistic, we don't have a lot of time with kids. We know lots and lots of kids are using. We want to do something, but we don't necessarily want to devote a lot of our clinical time to that. It also turns out that we've learned through some studies conducted here at Children's by some of my colleagues that kids are really expecting to get health advice when they go to a doctor or another clinician. And so they are particularly receptive to hear what we have to say. And when we can connect substance use to bad health outcomes, they're ready to listen, and brief advice turns out to be quite effective. For those who screen positive into the high-risk category, we need to do a brief intervention, which will include a little bit of an assessment to make sure that what they're doing that if they're doing something so risky that we need to intervene immediately, or to determine whether they've already developed an addiction and need to be referred to ongoing care. Either way, they need a brief intervention that will be targeted at getting them to reduce their use, getting them to eliminate entirely any very high-risk behaviors, and hopefully getting them to engage in treatment and to come back. And those who are in the acute risk category will need an immediate intervention, and I'm actually going to give an example of that in the third session today. Okay, so here is one sample screen. So I don't know who in the audience has heard of the CRAFT screen, but it's a popular tool. CRAFT is a mnemonic acronym. Each of the letters in the acronym is the first letter in a keyword in each of the tool's 6 questions. I am I do have those questions coming up in just a couple of slides, and so I will show them to you. But basically, when you're using the craft, you actually need to start with a pre-screener. So the American Academy of Pediatrics recommends 3 simple opening questions, and that is just, in the past 12 months, have you had a drink with alcohol in it? And by that, we mean more than a few sips. Have you smoked marijuana or used any other substance to get high? If the answer to all 3 of those is no, they automatically they fall into the no use category. If it's yes, they need to go on and administer a screen to determine their risk level. Okay, and so the craft is a screening tool. It's very easy to administer. This slide has the set craft 6 questions that can be really read right off of your visit form paper or a pocket card or an electronic medical record. And each question that's answered yes is scored 1 point, and typically a score of 2 or greater is considered positive as somebody who is high risk. A score of 0 or 1 is considered low risk, although I will say that even that was based on using an ROC curve, which is a statistical technique for maximal efficiency. But I will say that some practices may decide to use a craft score of 1 as positive, because 50% of kids who have a craft score of 1 will actually have a substance use problem. And so, you know, deciding where to set the cut point, I think, would be something that people in a practice should sit together and decide. This is I'm not going to show a lot of data, but just a little bit. This is what's known as the positive predictive value of the craft score. Basically, on the x-axis, I have craft score from 1 to 6. And on the y-axis, I have the likelihood that an individual has a diagnosis of abuse or dependence. And you can see that even at a craft score of 1, there's nearly a 30% chance that an individual actually has a substance use diagnosis. And it's about nearly half of them will have had one or had at least one problem associated with substance use, even though they may not meet criteria for substance use disorder. And you can see that as the craft score increases, this number marches right up, and that shows us that we're getting at different domains, and suggests that the craft is a very efficient way to screen kids. So the craft is a very efficient way to screen kids, but it's not the only way. In 2011, the NIAAA put out this guide, which may look familiar. It was mailed to lots and lots of pediatric and family practices across the country. So it may be laying around. If it's not and you'd like it, you can order it from the NIAAA, and I can provide people the website on how to do that. This is a 2-question screen. It's only about alcohol. It's got a number of advantages. It's very quick. So if you don't have a lot of time with a patient, you may be able to ask just 2 questions instead of really 9 with the craft. It was created from a national data set, so it's empirically based. It was meant to screen kids down to age 9, which is before alcohol use begins in most kids. Most kids initiate substance use with alcohol. That remains true in 2013. And so if you screen for alcohol and it's negative, most likely especially with younger children, most likely you've got somebody who's a non-user. And so that may be all you need to do. The other thing that's really important about the alcohol screening guide and the tool is that it has 2 questions. One is looking at current risk, and the second question is really trying to look at that trajectory. So, okay, this person in front of me may be in the low risk category, but is there anything I can say about where the trajectory is going? And that may really cue us into thinking about how to follow an individual, or it may make us think about how we want to implement an intervention. So when should I use an alcohol screen? Well, I would consider it certainly with very young patients, as young as certainly in the 9 to 12 age group. The craft has only been validated down to age 12. And so if you want to start screening younger, you might consider this tool. I think a lot of clinicians find it easier to talk to younger kids about alcohol than to talk to them about marijuana and other drugs. And certainly, I think we all feel like we don't want to imply to kids that we're, especially young children, that we're expecting them to have tried marijuana or even know what it is. And so we may not be comfortable asking those questions for very young children. I think it's a great tool to use when time is limited because it is so short. I think if you have a patient or parent who's presenting with a specific concern about alcohol, it's a great tool to use because with one question you can get a risk estimate right there. And it's also, again, helps us really gauge that trajectory. How do you do it? Well, you basically ask the two questions. One's about friends drinking, and the friends drinking is looking at trajectory, and one's about own drinking, and own drinking is looking at current risk. Here are the questions. They're all printed in the guide. Basically, the questions are asked with slightly different wording and different order depending on how old the child is. Generally, kids in elementary school use a backdoor approach where we're asking about friends drinking first, and we're not assuming anything. By the time kids get into middle school, we're still asking about friends drinking first, but we're using a different formulation of the question about your own drinking. Instead of asking, have you ever drank alcohol, we're asking, in the past year, how often did you drink alcohol? And it turns out that this formulation of the question is more sensitive than asking about ever drinking. In the high school age range, we're asking about individual use first because with older kids, it just felt more natural to clinicians who served on the panel who helped develop this tool. And then there's the question about friends drinking as well. And once you get the answers, it's really this is the chart we use to determine risk level, and this is really all based on that question about your own drinking. And this is to estimate current use level. Now, obviously, this is a complicated lookup chart. It can be programmed if you're using an electronic medical record so that you put in the age, or presumably the EMR would know the age, put in the number of days in the past year that the patient drank, and it will generate a risk level. If not, there are some complicated guidelines and mnemonics people have created to try and help people remember what the cutoffs are, but I think we have so much to remember, I have to look it up on the chart each time. So now that's the overview of screening. Now, once you've done your screen, you're gonna figure out if the kid is no use, low risk user, a lower risk user, moderate risk user, or high risk user. Now we have to figure out what to do with them. And so these are brief intervention goals, and obviously they differ depending on the risk level. So kids with no use, we want to give them positive reinforcement to delay initiation. Kids who have used, but their use has been limited and is not associated with problems, we're going to give them brief advice. And really the goal here is to encourage cessation. Those who have used and have problems but don't seem to have substance dependence, we're going to do a brief motivational interview, and the idea is to encourage cessation or reduced use, and also to target any high-risk activities that the adolescent may be engaging in, and also to actually encourage engagement in this conversation, to try and get them to come back and talk about it again, and to consider it part of medical care. Those who have substance dependence need a referral for further assessment and ongoing treatment. And here we're going to use the same type of brief motivational intervention, but our target is our primary target is going to be different. Of course, we'd like to negotiate less use, and of course, we should focus on highest risk behaviors. But really, the goal would be to hook that individual up with ongoing treatment. So I'm going to use the next couple of slides to talk about what to do with non-users and lower risk users, and I'm going to use a couple of cases to illustrate how this is done. And then at the end of that, we'll take a little break for some questions, and in the final session, I will talk about what to do about the high-risk users. So kids who report no use, they should get a few words of encouragement from a physician or clinician, basically for making good decisions And this kind of positive reinforcement, it turns out, may delay initiation of substance use. Oops. So I don't have a chart here, but some of my colleagues here at Boston Children's Hospital did a study in which they, in the first leg of the study, all they did was they went in and they collected data on what happens with kids over time when they're getting regular routine medical care. And then after doing that for about a year, they went in and they taught the physicians to do screening and brief intervention. They gave them a 45-minute educational seminar, very similar to what you're receiving now, and they asked them to implement that. And they found that physicians, these were all pediatricians, they found that they all found it very easy to use this information and incorporate it into their routine medical care. And what was astonishing was that kids who were seen by pediatricians who had been trained to give positive reinforcement and positive reinforcement were about 50% less likely to initiate alcohol use within 3 months of their physician's visit compared to kids who just got regular treatment in the first leg of the study. So that was pretty astounding reduction. It was statistically significant, and even more surprising, that effect held out to about 12 months. So just very few words of reinforcement and or health advice do have a tremendous impact, or can have a tremendous impact on kids. So this is Julie. She's a 14-year-old girl who's presenting for an annual physical. She reports no past year use of any substance. She's not ridden in a car with an impaired driver. And so her brief intervention is just positive reinforcement, and here it is. This is text that you could say to Julie. You've made some very good decisions in your choice not to use drugs and alcohol. For the sake of your health, I hope that you'll keep it up. And I want you to know that you can always ask me any questions you may have about them. We felt that it's really important to keep the door open because if Julie may not have any substance use now, but that could change over time. And so we want to be careful not to craft messages that will make her embarrassed to come and talk to us about or report honestly later. And so thinking about how to leave that door open, we think is really important. So that's very straightforward. And this is Brian. He's a 16-year-old who comes in for a sports physical for a swim team, reports no past year use of any substance, but one time he accepted a ride home from a party with a friend who had been drinking. So this kid needs an intervention. By the way, as we said at the very beginning, this is common. 24% of high school kids will tell you in the past 30 days they've ridden somewhere with an impaired driver. Again, this is a behavior that is associated with mortality in adolescents. And so we want to do an intervention focused on car safety. And so really what you want to do with Brian is brief advice. It's really just a form of education. Please don't drink with anybody who's even had a single drink. It turns out that teens and adults alike are notoriously bad at gauging their own impairment. So this is even worse in teens because there's a natural phenomenon to overestimate your skills during the adolescent years. Again, this might be very adaptive as a species. We need adolescents to do things that are very risky. We need them even in modern times. We need them to leave home at some point. And I think that if they very accurately assessed all their own skills, it might be hard to get them to take off on their own. And so this is natural and may even be adaptive, but it's very, very problematic when it comes to things like assessing whether they are too impaired to drive. And so the rule is, even a single drink, no driving, and that's consistent with most of the states that have no tolerance laws for adolescent drivers. And so you want to talk to Brian about alternative safe ways of going home, and that'll depend on where you live, whether it's going to be a subway or calling a parent or guardian, or getting a ride home from a non-user, if that's at all possible. When all else fails, sleep overnight and then go home in the morning when it's safer to travel. Call for a safe ride from parents. And, you know, kids will sometimes have their own ideas, and of course their own ideas are often the best ones, so engaging them in the conversation is particularly important. We recommend using the contract for life, which is available at the URL here at the bottom of the slide. Basically, the contract for life is, so here it is on the left, and basically it's an agreement between an adolescent and a parent, and really what the kid is saying is that they are assuring that they will never ride with an impaired driver, and what the parent says is, okay, I will ensure safe transport home for you, so that you never have to worry about how you will get home. And that could either be by I'll go pick you up, or I'll send a cab over, or whatever it's going to be. And this is an important point, I will not ask any questions in the heat of the moment. You can imagine that if mom or dad gets a call at 2 in the morning saying, hey, you know, I'm stuck here and I need a ride home, they're going to have very mixed feelings about the call. Their first feeling is, oh, thank God you called and you didn't hop in the car with the person you came with who's now drunk. And at the same time, they're also going to feel like, wow, it's freezing outside, it's 2 in the morning, and I'd like to go to sleep, and now I have to go drive you. And what were you doing out with all these people who are drinking anyway? So that is really not a good state for the parent to have a conversation with their child about what happened. After a little time has passed, when cooler heads prevail, perhaps the next morning, perhaps the next afternoon, then I think a conversation would be appropriate, but really not in the heat of the moment. And that's just to make adolescents feel like they can call without having to listen to a very painful harangue on the way home. Okay, so moving on now, let's talk about kids who report past year substance use but screen negative or as lower risk use. So for those kids, we basically want to advise them to stop using alcohol and drugs. It's pretty straightforward. We want to provide relevant medical information. Again, it turns out that when kids come to see a clinician, they are expecting to receive health advice, and they're very receptive to it. You know, we didn't really ask them in these studies, but I suspect that they are not particularly interested in receiving legal or moral advice from their physicians. And so, you know, when I teach residents or other physicians, I really encourage them to keep everything focused on the health and mental health effects, particularly as may be relevant to the child as they know them, but really stay focused on the medical. And certainly there's enough there to talk about that we really don't have to augment it with anything else. So this is Marcus. He is a 16-year-old boy who comes to the office after injuring his ankle at football practice. And you screen him, and he says that he's been high on marijuana on several occasions, but not at the time of the injury. He's never used other drugs, and his CRAP score is 0. So he's really used marijuana a handful of times. So this kid is in the lower risk category. And here what we want to do is give him brief advice. Here's some suggested talking points. You always want to tell him straight out, you know, as a clinician, as a physician, as a counselor, as a mental health counselor, whatever your role is, I recommend that for the sake of your health and or your mental health that you stop smoking marijuana altogether. We know that heavy marijuana use can affect concentration. Over time, it can impact mood and even affect your performance on the football field. You're such a good athlete, I'd really hate to see anything get in the way of your future. And so we want to do something that's really strengths-based. Here's what I'm concerned about. I'm concerned about your performance on the football field. I would hate to see anything get in the way of that. I know you are too. And the truth is that marijuana can interfere with your health and your brain and its development. And so the best way to protect it is to stop using. So this is, again, pretty straightforward. It's done fairly quickly. Here are some more sample brief advice statements. And of course, there are lots of them. This is just some that we made up. So Remember that alcohol and marijuana can affect your weight and your appetite. I'd be really careful with this one. You know, I think it's true, and a lot of healthy adolescents would be really receptive to hearing that message. I would want to be careful with anybody suspected of having an eating disorder. So marijuana directly affects your brain and your ability to think clearly. It can hurt your school performance and grades. Kids make bad decisions when they're drinking alcohol or using other drugs. Alcohol impairs memory, can affect your learning, and there are lots and lots of them. You know, alcohol is also associated with stomach problems like gastritis and stomach cancer, can interfere with medications or worsen an underlying disease, and that may be appropriate if you are seeing an individual who has an underlying disease. Marijuana can result in gynecomastia, which is growth of breast tissue in males. It results in decreased fertility, problems with mental health, increases the risk for depression, anxiety, and schizophrenia, all the things that we already talked about. You certainly wouldn't list all of these. You would choose a couple that seem to be particularly relevant or particularly striking and deliver those. And again, in the same study that I described earlier in this presentation, it turned out that adolescents who got brief advice were significantly more likely to stop smoking for the 3 months immediately following their physician visit compared to kids who got treatment as usual. So it's really remarkable that such a simple intervention works, but it looks like it does. And I think that that's really good news because it moves us out of the helpless and into a different category where we've got tools. We can use them. They're, not only do we have them, but they're actually pretty easy to use and pretty efficient. So when we're talking about adolescents who fall into the higher risk group, we want to do a brief motivational intervention. These interventions are based on the principles of motivational interviewing, which we're going to go over in the third section. The goals here are to reduce use, eliminate the highest risk behaviors, and to engage in treatment. For some kids, we need to consider a referral. Kids who are screened as high risk and are under are 14 years old or under, you know, we don't, you know, even without the friends question, we know that these kids are on a very high-risk trajectory, and so referring them, having them talk to a specialist, either a mental health professional who's got a particular interest in substance abuse or an addiction professional who's got an interest in working with adolescents, would probably be a good idea. Anybody who's reporting daily or near daily use of any substance is more likely than not already developed dependence and should probably be referred for more evaluation, more than just a brief intervention. Anybody who's reporting alcohol-related blackouts, which is just the term for anterograde amnesia, right? So it's kids who are drinking so much that even though they can still walk and talk, they can't remember the details, or substance use-related hospital visits. This is a very high-risk crowd, and they should probably be referred. Anybody who mixes drugs, particularly alcohol with other sedatives or even with amphetamines, those kids are at risk of hurting themselves and should probably have a closer look. We recommend that kids who exhibit certain behaviors that are extremely high risk for acute danger should get what we call an acute intervention. This is really beyond the limit of brief motivational interviewing, which is based on negotiation. Here, we want to do a little bit more of a takeover because we're afraid that the child might inadvertently injure himself or another, but more likely himself. So these are the kids who report very heavy alcohol use. So this we have defined as twice binge for age and gender. Those who are mixing sedatives, in particular drinking alcohol mixed with opioids or benzodiazepines, who can accidentally overdose. Those who are taking unknown pills, that might sound strange, but it turns out that this is more common than you might imagine. And those who are using IV drugs, at least if this is a new behavior or previously undisclosed behavior, they probably need some immediate intervention. And again, I'm going to talk about all of these categories and give some samples of how to do that in the third session. So now I want to talk about Jane, just to sum up. She's an 18-year-old girl with a past history of a language-based learning disability. With hard work and academic support, she's graduated high school in the middle of her class. She lives with her 2 parents and 2 younger siblings, and she's going to be the first member of her family to attend college. And she reports occasional drinking with friends at parties, but she denies ever using illicit drugs. So actually, she's a whole lot like James. There's nothing really particularly concerning about her presentation, but her doctor gives her the meningococcal vaccine, discusses academic support services available to her at college. But here's where her PCP does something a little bit different than James's. Okay, so he asks the car question, and she says, you know, although she has not used drugs in the past year, she has ridden with an intoxicated driver. So her PCP talks to her for 2 to 3 minutes about car safety. He gives her the contract for life to bring home. She agrees. She signs it right there in front of him. She says she's going to take it home and talk with her parents. So here's Jane's epilogue. 3 days later, she attends an end of the summer party with some of her high school friends. Her boyfriend, Jim, who had driven her to the party, has been drinking heavily. Jane recalls signing that contract for life. When it's time to go home, she calls her parents for a ride home. Jim gets very angry. Why aren't you coming with me? I'm fine to drive. And he storms off, gets in his car, and leaves without her. And her epilogue is that 4 years later, Jane graduates from college with honors, and her parents are very proud. And I'm actually going to pause again and ask at this point if there are any questions in any of the material that I've presented from either of the 2 presentations.
Yes, I do have a question this time, and I don't know if it's going to be covered in a future case study or not, so we'll just do this now. What is the best treatment approach for adolescents who have ADD or ADHD and are active marijuana users or have marijuana dependence?
So thank you for that. That's a really good question. You know, I am actually a developmental behavioral pediatrician, and this is like a burning question. That's like the million-dollar question. What we know is that adolescents with ADHD are more likely to try substances, and beyond that, they're also more likely to become dependent on substances, and this is a big problem. We need to be screening them. We need to be talking to them. I think that, you know, this is not going to answer your question exactly, but I think the key in kids with ADHD is prevention, because we know that once they initiate, they are more likely to develop a substance use disorder, and that's unfortunate, but that's the reality. So we want to prevent as much as possible. Unfortunately, so I would say that a kid with ADHD who's developed dependence, just like any other kid who's developed dependence, you probably want that kid referred on. This webinar is really focused on screening and brief intervention. You know, I think one of the keys to screening and brief intervention is knowing your limits. And so, you know, a kid with dependence is probably at the limit. And so, you know, what I would work towards is trying to engage him to follow up on a referral and really engage in treatment specifically for substance use disorder. In terms of which treatments are most effective, I think that that's an open question. There have been lots of people who have posed it. You know, it's really beyond the scope of this webinar to talk about it in detail. What I will say is, unfortunately, all of the treatments that we use for substance use disorders seem to be a little less effective in kids with ADHD. I'm sorry to say that. Some seem a little better than others, but overall, I would say the key is really engaging them.
Okay. I've got 2 more. The first is, what about a youth who denies use?
So I think the implication in that question is, what about a youth who's really using who says no when you do the screening? Is that what the question is? Well, I think that's what the question is. You know, I think to some extent that's the limit of screening. Not everybody's going to be honest with us. You know, you might think that nobody's going to be honest with us, but it turns out that that's not true. You know, there's lots and lots of work that shows that, you know, if you if you do it right, and basically it's not hard to do it right, you have to talk about confidentiality. You have to make sure parents aren't in the room. You have to really be non-judgmental in your approach. But if you do those things, most kids will be pretty honest with you. Clearly not everybody, but most kids will, and it means that it makes screening worth doing. What I will say is that sometimes we find out about an adolescent substance use through other means, like a parent's reporting or school's reporting. And, you know, I would say in those cases you can skip the screen and, you know, do a little bit more of an assessment and figure out what's going on and make some clinical judgments that way. And I will talk about some assessment tools and as part of the brief intervention that may be useful, even if the use was discovered not through screening but through some other mechanism.
Okay. Can you describe the difference between brief advice and brief intervention?
Yes. So thank you for clarifying. I think the terminology is a little unfortunate, but this is what we have. So when we talk about brief advice, so often we use the term brief intervention as an umbrella term, okay? So it includes brief advice, which is really just making a statement to a kid. So there's no negotiation involved here, but we're really just saying, you know, I recommend that you don't smoke marijuana at all for the sake of your health. You know, you probably won't be surprised that as a social worker or a mental health clinician or whatever your profession is, we don't recommend marijuana use. And then tying that to the medical or mental health reasons. That's brief advice. There's no negotiation involved. You're really just delivering a message. Brief intervention, brief motivational intervention is a different type of brief intervention, and it's really meant for the higher risk kids. And I'm going to show in detail in the next session exactly what I'm talking about there. But really, we want to get into a little bit more detail. We want to use the tools of motivational interviewing to explore ambivalence and then use that ambivalence to encourage kids to cut down or stop.
Okay. Do you want one more?
Sure.
Okay. What would be the benefits and drawbacks of using the CRAFT screen if one has a positive screen to initiate brief advice intervention? I think this is this typo in there. What would be the benefits and drawbacks of using the CRAFT screen for either a positive screen to initiate brief advice or an intervention?
So, you know, I think that the CRAFT is a really excellent tool. It's well validated. It works really well with kids. It's pretty easy to do. It's 6 questions. Doesn't really take all that long to administer. You know, it really does a good job of separating lower risk from high risk kids. So I think there aren't a whole lot of drawbacks. You know, if there's one, sometimes people find 6 questions, or it's really 9 questions, because you got to ask those 3 opening screening questions. They feel like that's a little bit more than they can get to. The CRAFT also asks about, it combines risk, alcohol, and other substances. And so it'll give you a sense of risk, but it's not substance specific. So once you get your result, for a higher risk kid, you have to do a little bit more digging. I think it's a very good clinical tool, and it could easily be incorporated. I don't see too much downside to using it. You know, some people prefer the alcohol screen because it's just 2 questions, and so you know that's easier to administer in some ways. But I have to say, both are recommended. I think they're both, you know, I think they're both perfectly reasonable choices and excellent tools.
Okay, that's it for the questions, so you can continue now. Thank you.
Okay, good. So this is the last session, the last third that I've put together, and I want to talk about now the brief motivational interview, okay? And so, again, these are the interventions that are really specifically targeted to high-risk kids. And the basis of brief motivational intervention, so these interventions are based on motivational interviewing. Now, I'm sure that there are a lot of people in the audience. I can't poll people. I can't have you raise your hands because I can't see any of you, but I'm going to make the assumption that lots of people are familiar with it. And, in fact, my assumption is that lots of people in the audience are much more familiar with it even than I am, that people who are counselors probably do this all the time. But just very brief, for those who may be less familiar, motivational interviewing, what it is, it's a counseling style. It's collaborative, it's patient-centered, and it's a method, it's a form of guiding a patient to elicit and strengthen motivation for change, okay? The spirit of motivational interviewing, it respects a patient's autonomy, right? It recognizes that you know, patients are going to do what they're going to do. It fosters patient-centered collaboration. Here's the goal. Like, let's figure this out together. You know, you can have my recommendation, but how do you want to go about it? How can I help you? And the key here is that it evokes or elicits the patient's own reasons for change, okay? Now, there's a growing evidence base for MI. So a recent meta-analysis that included 21 MI studies with adolescents found a small but significant reduction in substance use, which is sustained over time. Okay, now these studies were looking at motivational interviewing with adolescents as a form of therapy. So this was not a 5-minute brief motivational intervention. These were kids who came in for 5 sessions that were each 1 hour, and they would do motivational work. And it looks like it's a very useful therapy for that kind of work. And it's recognized by SAMHSA's National Registry of Evidence-Based Programs and Practices. And it's particularly well suited for brief interventions, because one of the beautiful things about motivational interviewing is that behavior change can be accomplished with even very brief counseling. And that's one of the miracles of MI. So it's kind of the opposite of psychoanalysis. You can start seeing behavior change in some cases, after just a few minutes. So there are a couple of core assumptions of MI that are important. And the first one is that motivation is a state, not a trait. So, you know, we'll sometimes hear parents or other adults say, you know, he's just an unmotivated kind of kid. Well, that's assuming that motivation is a trait. It's inborn. You're either born with motivation to do stuff or you're not. And largely we think that that's wrong. And motivational interviewing assumes that it's wrong, that motivation is actually a state. It can be influenced by interpersonal interactions. When we give lectures, when we order people to do things, when we tell an adolescent to change an entrenched or pleasurable habit, really what we're doing is we're eliciting resistance, right? Because we're coming up against that person's agency, right? That person's sense of having an independent decision-making capacity. On the other hand, if we work collaboratively, we can actually elicit ambivalence, which is natural. And we can use an individual's own reasons for wanting to change behavior to result in increased motivation. The second assumption is that ambivalence to change is absolutely normal, right? So stress, frustration, anger, and resistance may actually indicate that the individual is really seriously considering a change, okay? And so you know, when we see these things, you know, sometimes it's reaction as a clinician is to get frustrated back. This kid just won't do it. He can't, like, it's getting, you know, it's just getting angry. Well, you know, the other way to think about that is that anger might indicate that he's really serious, because it's very easy for a kid to sit and tell you what you want to hear, and I'm sure you've all had the experience of kids doing that. But that's not necessarily what we're looking for. So the principles of motivational interviewing are very straightforward. Basically, we want to, so I have this listed third, but if you look at that third point, we want to develop a discrepancy. We want to find out what are the problems that have been associated with substance use already, okay? And we're only applying this to the higher risk group. And the assumption is that by the time you're in the higher risk group, you've had problems associated with your use. That's really what that determination means. And when we do validation studies, that's what we're looking at. And so we're going to find out, hopefully very quickly, and I'll show you some tricks, what exactly have those problems been, and how is the kid reporting those problems. And we're going to help bring those problems to the surface and talk about them to really develop the discrepancy between, you know, what the kid really wants to do and what the kid is actually doing. Now, when we do this, we're going to be very empathetic. We're certainly going to support self-efficacy, because if a kid doesn't feel like they will ever be successful, then there's no point in trying, right? And another key is we're going to roll with resistance. So resistance really means that we've gone too fast. We've jumped ahead of the patient, right? We're on to the next step. The clinician's on to the next step, and the adolescent isn't. And when we see that, we want to roll back to a place where we had mutual agreement and then start again. Now, these are the MI principles. Again, for MI clinicians, these will be all very, very natural. We're going to really boil them down in brief motivational interventions. I'll do that in just a second, but I just want to start as a basis of where these ideas are coming from. So expressing empathy, it's actually pretty simple, can be done in a variety of ways. So we recommend that you start by asking permission to discuss personal topics, right? Acknowledging and validating strong emotions, or even just giving kind of nonverbal responses to signal that you're listening, you're paying attention, you're not judging, and that you find this conversation really important. Supporting self-efficacy, again, kids, patients, all patients, everybody needs to believe they're successful in order for them to even be willing to attempt to change. If you feel like you can never do it, why even try? We want to give positive messages about strengths. This is really important for kids with drug problems because they've already gotten, I can guarantee you, they've already gotten a lot of negative messages. And so just coming in there and saying, you're a really smart kid. You've got a lot of strengths here. Will really get their attention and get them listening. They don't hear that very much, sometimes not at all, and certainly not enough. Okay, so developing a discrepancy. Again, we're talking about exploring problems that have already occurred, exploring both positive and negative feelings, but really we're trying to bring the negative to the surface. This is for high-risk kids, so those who have already had problems, and exploring the consequences from the patient's perspective in order to move them towards agreeing to a behavioral change. Rolling with resistance, avoid arguing. If you get ahead of the patient, pull back, get to a point of common ground, or simply acknowledge a point. Avoid arguing, avoid lecturing. That actually has the opposite effect, right? Results in decreased motivation to change. So this is a list of MI tools. You can use open-ended questions, reflective listening, affirming, negotiating, reframing, summarizing. A lot of these words will be familiar. Here are some examples of little fragments of vignettes. So open-ended questions are any question that can't be answered with a single word, right? And they are a particularly useful tool to initiate conversation or even more so to explore areas of ambivalence, right? So here's John. He's 17 years old. He's been driving a car for the past year. He hasn't had any accidents. However, he often drives home after drinking at a party, and when you ask him about that, he says, well, I don't see what the big deal is. I can hold my beer. I know when it's safe to drive and when it's not. And then he throws in, and anyway, my dad's car has an airbag. And so, here is an area that, so John is presenting as someone who's in pre-contemplation. He's driving after drinking, and he thinks that's just fine. And we want him to think about that a little bit more. So here we're going to say to him, well, I appreciate that your dad's car has an airbag, but what would happen if you did have a car crash, right? And really let him think about that and talk about that. It's, that airbag going off is not necessarily a good thing. So reflective listening involves repeating or just slightly interpreting what a patient has said for emphasis. And reflections can help to flesh out ambivalence and really try and capture them in a patient's own words. So here's an example. Here's Maria. She's 16 years old. She's been smoking marijuana with her steady boyfriend for the past year. Her grades have fallen. She tells you, I love Jack, and he wouldn't be interested in hanging out with me if I quit, right? So there's her ambivalence. It's right there open for you. And so here's the reflection. So you really like Jack, and he encourages you to smoke even though you don't want to, right? And then you're going to follow that up with an open-ended question. What do you think you should do about that? And leave it to Maria. So it's, you're just taking her own words, her own ambivalence, and asking her to think that through and make a decision based on it. So affirming is the act of commenting on a patient's strengths in order to build self-esteem, right? And affirmations can help to set an empathetic tone and also support self-efficacy. And of course, they should always be genuine. We shouldn't affirm qualities that we don't really think are there. I mean, that might work with very young children, but adolescents are typically good at knowing what they're good at and what they're not. So here's Kareem. He's a 16-year-old boy who comes to your office at his mother's insistence because of marijuana use. Kareem doesn't think marijuana use is harmful, and he doesn't really want to make any changes at this time. Yeah, I know my mom yells at me, but she's just making a big deal out of nothing. He spends a lot of time talking about the difference of opinion between him and his mother. So here's your affirmation. I can see that you're very scientifically minded, and you really did a lot of research. You know quite a bit about marijuana. And here's your open-ended question. Why do you think your mother is so worried about your marijuana use? So here what you've done is you've taken a little bit of his argument off the table. You've acknowledged, you've affirmed, I can see that you know a lot about this. And then you've shifted the conversation. So it's your mom, huh? She's the one who's really worried. What's going on? What's she thinking? And the reason to do this, and personally I use this a lot with adolescents, is because it's very typical for adolescents to project their own thoughts and their own ambivalence onto a parent who's telling them not to use substances. And so this could really be a very nice entree into discussing really what is their own thoughts. Okay, negotiation involves setting goals that a patient accepts as meeting his or her needs, right? So it's, let's making a plan together. And it can help to ensure that the clinician doesn't get ahead of the patient, but it can also signal the importance of a patient's point of view. So here's Taylor. Taylor's a 17-year-old girl who's coming in for a physical. You screen her, and she tells you that she recently tried cocaine while she was drunk, and she had a bad experience. She doesn't want to use cocaine again, but she gets annoyed at the suggestion that she stop drinking. So here the clinician got ahead, right? She's getting annoyed. She's resistant. So here's what the clinician does. She says, well, as your doctor who cares about your health, I recommend that you quit drinking until you're older because teens often make bad decisions when they're drunk, right? It probably won't surprise you that as your doctor, I'm going to tell you I recommend that you don't drink. But we both know that you need to decide for yourself what to do. I'm wondering, how can you protect yourself from doing things that you regret in the future? Okay, and so that's trying to roll with the resistance, trying to bring the conversation back to where Taylor will engage in it. And reframing involves examining a patient's perceptions in a new light or in a reorganized form to give new meaning to what has been said. So here's Donna. She's 15 years old, and she recently committed to stopping to drink alcohol after a school suspension, right? She got frustrated with herself. She said, I realize now I shouldn't do this. She did well for a couple of weeks, but then she was at a friend's birthday party, and she had a beer last weekend. And so she's pretty down on herself when she comes in, and she's feeling like, why even bother? I can't really do this. And so you just simply reframe it for her. So in the past couple of months, you only drank once. That's a really big change. And now, help her build her self-esteem, and now let's go on. So what was happening last weekend when you decided to have a drink, and what could you do if that ever happened again? So now it's time to explore it in an open-ended way. So summarizing is a way of pulling a long discussion together, and it involves reflecting back various factors that are going to underlie a patient's decisions and behaviors in order to help weigh them out, right? So this is what you've said, this is what I heard. Let me put this together for you. So careful summary also demonstrates, of course, that you've been paying attention and that you're understanding the patient's point of view. And I use summaries a lot at the end of every clinical interview. I do a summarization, and I always start my summarization by saying, look, here's what I've heard. Please correct me if I've gotten any of this wrong. And sometimes kids do. Sometimes, I didn't really mean it that way. And it's important to get them involved in that way. So here's Tom. He's 19 years old. He was kicked out of his dorm because of drinking. He wants to stop so that he can go back to school, but he's worried that it's going to be difficult when he's with friends who drink. He's decided to get a job on Friday nights to keep him from going to parties. He also has been spending more time with his friend Jake, who does not drink. And so you summarize that back, and you say, well, quitting drinking is hard, but you've decided to do it. Your work schedule is going to keep you away from parties. You can spend time with Jake if you don't want to be around alcohol. It's great that you want to get back to school. And then you always end with an open-ended question, right? So what else can you do? Is there anything else that if you do find yourself around alcohol that would be helpful to you? Okay. So those are the basic skills and some ways in which they might be used. And now we're going to put it all together. And we're really going to talk about a brief motivational interview. So this is a tool that you can use to address high-risk substance use really in about 5 minutes or less. Okay, so it's not motivational interviewing, which even though it's quick, can be, hour-long sessions at a time. We're really going to try and do something that can be incorporated into the course of something else, right? So this is a kid you're seeing for some other reason, but you do the screening, kid's high risk, you want to do an intervention, even though that's not really the point of the session, okay? So brief motivational intervention. So traditional MI is framed in the context of counseling, right? The MI toolbox is very versatile and can be effectively employed even in a fast-paced setting, right? So this is a simplified version of our algorithm, and here, this is where brief motivational interventions fit in, right? So this is a kid who's screened for high-risk use, is positive, they're going to get a brief motivational intervention. And so here's how you do it, okay? So these are the steps. So first of all, I recommend introducing this topic, right? Start by asking for permission. So that could be something like, I'd like to ask you some follow-up questions about your use of alcohol. Can we do that now? And this really signals that the adolescent's opinions are respected. It also sets an empathetic tone. Now, of course, the caveat here is that some kids, and most kids will actually say yes. I do this all the time. Most kids say yes. But some kids may say no. And if they say no, of course, you can't override that, right? Then there's no point in asking if you're just going to override it. So you have to respect that. And you really have to say, okay, well, if you don't want to address it today, I'm going to keep it on the list of things. We'll discuss it next time you're here because it's certainly not something that you want to let go. Okay, once you have permission, you want to do a very quick assessment. And the goal is to get a quick understanding of the types and severity of problems that have been associated with substance use. And the objectives are really threefold. First of all, we want to identify very quickly adolescents whose use puts them at risk of immediate harm. And for those kids, we want to make an acute intervention. So I'm going to get to that. I'm going to show you a kid who would fall in that category and how we deal with that. Then we want to also identify adolescents who've developed an addiction. And I would make the argument that we can really get a pretty good sense of that with a pretty quick assessment. In those kids, we want to send them for referral to a mental health or addiction specialist. And here, so we're still going to do the motivational intervention, but the goal, although we still might try to get them to reduce use and certainly to reduce high-risk use, really the major goal here is to get them to engage, come back, go to follow up on a referral. And the third thing is we want to identify areas of ambivalence that can be reflected on as part of the intervention. And in some ways, that's really the primary target because most of these kids will not fall in categories 1 or 2. So these are just some suggested assessment questions. So this is particular for alcohol, but they're similar. I'll show you my list for marijuana. They're similar. And you'll notice that most of them are not open-ended questions. The first one is, it's tell me about your use of alcohol. And, so kids will often tell, well, I started when I was 16 and, I drink once a week or whatever it is. But it'll get them talking a little bit. And then I ask them some very specific follow-up questions. And these are really, they're not open-ended. They're actually meant to be very quick and point me to areas that I need to spend more time on. So, how much do you usually drink and what's the most you've ever had? Because I want to know if this kid's at acute risk. Have you ever had a blackout or alcohol poisoning? So if they had, I'm going to explore that more. Can you tell me about that? How many times has that happened? What has that been like? It sounds like it's been a little scary. Have you ever had a problem because of alcohol? So that's an open-ended question, but if the answer is yes, so tell me about it. You're really going to be looking for them to talk about that. Have you ever done anything you've regretted because of alcohol? Slightly different than having a problem, because kids will talk about having sex that they later regretted. They'll talk about saying things or having arguments, or sometimes kids will tell me that they regret what their alcohol use has done to their family or their parents. Have you ever tried to quit drinking? Now, again, that's a yes or no question, but if the answer is yes, I want to know why, because if they've tried to quit drinking, there's something that's concerning them about their own drinking, and that's a little jackpot in terms of developing a discrepancy. And then I also want to know, does anyone in your family have an alcohol problem? Because, like it or not, your genes and play a big role in how likely you are to have an alcohol problem, and so that's something worth thinking about. So again, questions for marijuana, they're very similar, but so tell me about your use of marijuana. Have you ever been a daily smoker? Again, I want to know the likelihood that this kid is dependent, and certainly anybody who's done daily smoking is in a high-risk category for that. Have you ever had problems or gotten into trouble because of marijuana? Have you ever tried to quit? With marijuana, a lot of kids will tell me that they get lazy, they lose energy when they smoke, and many of them don't actually like that. And so talking about that can be really useful. Have you ever gotten paranoid? Lots of kids will tell me they got paranoid. It's a known effect of marijuana. Some kids will actually hallucinate, and that can be very scary, and actually can even be hard to bring up, but I think it's really important that we know that if that's going on. And once you've asked your question, you're really just going to summarize back what you've heard. So you really like drinking with your friends. You can't imagine quitting. You've had a couple of blackouts, and that's been scary for you. So how can you protect yourself from having another blackout, right? So, that's pretty straightforward. Now, I always include in my brief interventions frank advice to quit. And this is just like brief advice, and I include it. And I do that even though it's not a motivational interviewing tool or technique. I do it because I don't want kids, a lot of times when we make the plan, it's not going to be complete abstinence. That's just the reality. And I don't want kids to feel like I'm endorsing their decision to continue using. I want to make sure that they've heard my advice, although I acknowledge that they're the ones who are in charge. So I give advice like this. Well, we both know that only you can decide what to do. I recommend that you quit entirely for the sake of your health. A blackout means that you drank enough to poison your brain cells, at least temporarily. And as you know, kids often get themselves into trouble when they are blacked out. So this is just like the brief advice we give to the lower risk kids, but I include it here. And then I want to help them make a plan. So, okay, you don't want to quit right now, but you would like to cut down. How do you think you'll do that? And let them give a suggestion. Always use affirmations when you can. I think you're smart to cut down. Your plan is a good one. Would you please come back in a month or two and tell me how it is going? What do you think? And so, let them tell you if they'll come back or not, and if not, let them explain to you why. And then here's another piece that I recommend. So I recommend inviting parents into the conversation for all these high-risk kids. That's not the same as breaking confidentiality because the kid has the ability to say yes or no. But I think if you get into the habit of doing this, a surprising number of kids will say yes, particularly a kid who's just agreed to quit for a month or a kid who's really agreed to reduce. Most of these kids who are in the high-risk category, their parents already know they're using substances because they're in the high-risk category because they've already had some problems. They may have had a problem at school, or their problem might have been that their parents caught them. So, often their parents are already aware that something is going on, and so it's not really a secret. And now, if the kid has just told you, yes, okay, I don't want to black out again. I'm going to go 2 weeks without drinking just to see what happens. They might be really okay with you telling your parents that they've agreed to do that. So here it is. You said your mom caught you with marijuana and was very concerned. I'd like to tell her that you just spoke with me about it and you've agreed to speak with the social worker in our practice next week. What would you think about that? And let them comment on it. Okay, so now I want to pull it all together with a couple of case vignettes that I will use to finish up this webinar. So the first one is Katie. She's a 17-year-old girl who comes in for emergency contraception, and on screening she says she drinks alcohol and uses marijuana every few months, but she's never used other drugs. She answered yes to relax, family, and trouble questions, so her CROUD score is 3. You can do the math in your head. And so now you realize she's in the higher risk group, and so you're going to do a brief motivational intervention. So you're going to start by doing a little mini assessment here. So tell me about your use of alcohol. And Katie says she started drinking it at parties as a freshman. Now she drinks about twice a month, 4 to 6 shots, and that's enough to get drunk. She's never had a blackout or alcohol poisoning. She's never tried to quit. Her mother once told her that her distant cousin had alcohol problems. And have you ever had problems related to drinking? Katie said she was suspended for 2 days because she brought a bottle of vodka to a school football game last year. Her parents were upset and they grounded her. She said she would stop drinking, but actually she didn't. And now she's 18 and she thinks that they are less concerned. Have you ever regretted anything that you did when you were drinking? And she said, well, she had consensual sex at a party 2 days ago while she was drunk. So it was consensual at the time, but she didn't use contraception, and actually now she regrets the decision to have sex in the first place. And so you're really going to just reflect this back to her. So it seems that drinking has become an important activity for you and your friends. And it's also gotten you into some trouble. What would you like to do about it? Right? And that just gives you a chance, when she answers that question, you're going to get a good gauge of, where she's at. And so she says, so the first thing she tells you, and this is very typical, she doesn't tell you what she's going to do about it. She tells you what she's not going to do about it. So she says she has no interest in quitting because all of her friends drink, and she doesn't think drinking is a problem. She continues to say that she's done some stupid things when she was drunk, and she would actually like to control her drinking better. So she starts with this announcement for you that she's not going to stop. But she's willing to cut down, so you'll work with that. So here's the advice that I like to give. Well, we both know that only you can decide how often and how much to drink. As a physician, I think you won't be surprised that I recommend that you stop drinking entirely for the sake of your health, and because people often make bad decisions when they drink. How do you think you can protect yourself better in the future? So here we are. We're going to talk about the high-risk behaviors. She says, well, I'll have only 1 or 2 drinks when I'm out with friends. That sounds like a really soft target, but at least she's thinking about cutting down. So you give her some positive feedback, and is there anything else you can do? And she says, well, she can't think of anything else. And so at this point, you throw in there, well, do you think you could avoid having sex after you've been drinking? And she says, yeah, I think that's probably a good idea. And then she agrees to return in 1 month, at which point you need to do a follow-up medical visit anyway. And so, that's basically where her negotiation, that's basically the end of her brief intervention. When she does come back in 1 month, just going to ask her, so how did it go? Were you able to keep to 1 or 2 drinks? Have you had any more blackouts? Have you done anything else you've regretted? Have you missed drinking? Have you been in high-risk situations? There are lots of questions that you can ask in follow-up to see how she's doing. Okay, so moving on to Eric. He's a 17-year-old male who comes into the office with flu-like symptoms. He's screened, and he reveals that he's drank alcohol, smoked marijuana, and used several other drugs in the past year, including oxycodone. And actually, you go through the craft. His craft score is 6. And as you start talking, he just basically that's why he's there. He thinks he's addicted to opioids. He'd like to quit. He's actually very appreciative that you're asking these questions because he's having trouble bringing it up in the past with other professionals. He's actually tried twice in the past to quit on his own, but both attempts have been unsuccessful, and he thinks he needs some help. So this kid, in some ways, is low-hanging fruit, right? He's ready. He's ready to make a change, and so the key here is really just not to lose him. And so you asked Eric the criteria for opioid dependence. He meets all 7. Arguably, you don't even need to do this. I think a craft score of 6 with his history is probably enough to figure out that he's opioid dependent. And so now you want to assess his readiness. And so here we go. We've kind of summarized what he said. So from your history, it seems that you've lost control over your use of pain medicine. I know how hard it can be for patients to ask for help, and I'm really glad that you're here. Usually people who become addicted do need help to quit, and that could be anything from hospitalization to help with the withdrawal to an outpatient medication treatment program. What do you think would work best for you? So we're acknowledging his agency. We're giving him a menu of options and seeing what he selects. And he tells you right away he's not going to an inpatient program, but he would be interested in medications and counseling, and so your job here is to help him find an appropriate treatment program. And so, I think that at that point you want to identify local resources, and there are some national websites that can be helpful for this. SAMHSA has a treatment locator, but it may be more useful to use local resources if they're available in your area that can help you find both mental health programs and practitioners with experience in treating adolescents. and online treatment locators are also helpful. Now here's the other piece of it. For a kid like this, we want to involve the parents in treatment if at all possible. The best chance is for good outcomes is when a kid like this has support from his family. And of course, there are special considerations when parents themselves are using substances. So, I'll talk about that in more detail in just a second. So, we also want to remember that we need to treat co-occurring disorders simultaneously. Does he have ADHD, mood or anxiety disorders, or depression? He certainly is going to need a closer look at all of those things because co-occurring disorders are so common. And we need to have special caution with stimulant medications. Even if we are able to confirm a diagnosis of ADHD, we probably want to get him off other medications first before we consider adding another medication. Okay. So how do we invite the parents? So just like with other kids, we just want to ask, do your parents know about your drug problem? So if the patient says yes, you're a leg up, then it's going to be a little easier. And you could say something like, I imagine that they're going to be really happy that you're ready to go into treatment. So in my experience, kids do best when their parents or other family members are supporting them. So if you agree, I'd like to tell them that you're planning to start a treatment program and include them in some of this discussion. So again, I've done this with lots of kids over the years. It's often very difficult because they feel embarrassed. Even if their parents know they have a problem, they're often embarrassed to go through the details. But it also can be very, very helpful. And usually, if you can present this positively, usually the kids' worst fears are not actualized. They're worried that the parents are going to fly off the handle. But usually, and I've done this many times, usually parents are able to appreciate that their kid is reaching out and asking for help. And if they're not able to do that, you're right there, you're in the room, and you can help redirect them. So if you ask, do your parents know about your drug problem, and the answer is no, you need to do a little more screening. So what would happen if they found out? You want to know if there's domestic violence or active parental mental health or substance use disorders going on, because that'll change things. But if not, and in most of the cases it's not, you want to encourage the team to involve the parents or other family members. You can offer support in breaking the news. You can tell them, if I talk to your parents, I'm really going to emphasize that you're seeking treatment, and you can practice the wording beforehand. So I do this a lot, and kids will often have certain words they want me to use and other words they want me to avoid. So they don't want words like heroin out there, or even narcotics in some cases, but they want, they prefer words like pain medication, and that's fine. Parents can really, as long as you're giving parents the information you need, respecting how a kid wants that done is perfectly reasonable. Okay, so the third and final high-risk category is the kid who's in acute risk, and here we're moving a little beyond motivational interventions, there's a small group of very high-risk kids for whom we just can't do the give and take of a motivational intervention because their behaviors are putting them at such extreme risk. We have to find a way to make an immediate intervention. So this is John. He's a 15-year-old boy who was brought to the emergency department for altered mental status 3 days ago. A urine test was positive for marijuana and Xanax, and now John presents to you for follow-up. So you do a little screening, and he tells you in the past year he's used alcohol, marijuana, mushrooms, dextromethorphan, and benzodiazepines, and you do a CRAF, and it's 4, so no surprise that it's positive. So you're going to do a brief motivational intervention, or you're going to try anyway, so you get a little history, right? So the elephant in the room is this emergency department last week, so you start with that. So tell me how you ended up in the ED last week. So he says he was at a party with his friends. They had been farming with a PH, and what that means is that they had been taking unlabeled pills out of a bowl. He took a combination of 8 pills. He doesn't really know what they were, and he doesn't remember anything else until he woke up into the ED. And so, you want to know, boy, has this ever happened before? And he tells you, yeah, he's gone to farming parties before, and he often mixes drugs. And he said, I don't think I have a problem. I'm a kid we all do this, all my friends do this, it's like kids all use drugs, we all experiment. And he says he only ended up in the emergency department because he was stupid and he took too many pills. You also get a little more history. He uses alcohol once a week, marijuana every day, and other substances intermittently, basically, usually whenever he can. But he doesn't think he has a problem. He thinks he could stop anytime. He's not interested in treatment, and he thinks he's doing just fine. So here's a kid who really needs an acute intervention because this is the kind of kid who is going to inadvertently hurt himself if he continues with behavior like this. In fact, you might think that the emergency room visit would be a wake-up call, but unfortunately, some kids, they don't really get it. And so you need to really move on. So here are the points. Here's what I would recommend you do next. So you remind John of the limits of confidentiality and say, remember when we started this, I told you I would keep what we said confidential, but the limit of confidentiality is your safety. And if I was worried about you acutely hurting yourself, we'd have to figure out a way to bring other folks into the conversation. And in fact, that's what's happened here. And I think your parents need to be part of the conversation. Obviously, they know that you were in the emergency room and that you had been using drugs, and I would like to talk to them about what the plan is going to be here. So bring the parents in to discuss the need for treatment. For a kid like this, I would always screen for suicidal ideation, and if that screen is positive, I would refer to the ED. But if not, if he seems stable, I would make an appointment right away with a mental health or addiction specialist. And that, when I say right away, I mean that week, within 2 to 3 days. So this is really the kid who you're going to call in favors for, right? So remember when you got your favorite therapist's nephew into the practice quickly, right? So now you're going to call in that favor, and you're going to say, I've got a kid who really needs to be seen right away. Can you overlook him? You're going to contract with John and his parents that he won't use drugs at all, at least until his next appointment, and that he will keep his next appointment. And then you're going to pull the parents aside and tell them that they should call 911 or bring him to the emergency department if he develops altered mental status, or if they're acutely concerned about his mood or behavior, because, just in case he's not following your instructions, they need to be monitoring him. You can mixing drugs can really get you into trouble, even if you only take a couple of pills. Because I'm so worried, I have to share some of this information with your parents. I want you to speak about drug use with one of my colleagues who's a psychiatrist. In the meantime, can you promise me that you will not use any pills or drugs at all until you've had a chance to speak with him? And what do you think would be the best way to share the information with your parents? So just to kind of sum this whole thing up, so motivational interviewing techniques are especially useful when discussing difficult topics such as drug use. Brief motivational interventions use MI techniques to facilitate behavior change, and these are structured, short, practical interventions for use in the course of routine patient care. So this is to work with kids who have come in for some other reason, but you discover drug use. Ideally, patients set their own goals collaboratively with a clinician. All patients are advised to quit or cut down. Patients who have developed dependence are also encouraged to accept a referral to treatment. For adolescents whose substance use puts them at acute risk of harm, the intervention is targeted at safety, though MI techniques are used whenever possible. And I think that brings me to the end of this presentation, and I want to thank everybody for their patience and their participation.
Dr. Levy, we do have some questions for you.
Absolutely.
Okay. The first question is a clarification on a question that was asked previously, and it's saying that my last question was not clear. What would be the benefits and drawbacks of using a score of 1 on the CRAF versus 2 as being a positive screen to initiate the brief advice or brief intervention?
Okay. Thank you. So now I understand the question better. So really, the advantage is that you will pick up, if you drop the score to 1 to put somebody in the higher risk category, you will pick up more kids who've had problems related to their substance use. The disadvantage is that you will try to do a motivational intervention with some kids, about 50%, who really haven't had problems yet, and it's hard to do a motivational intervention in those circumstances. Really, you may end up just giving brief advice. Now, that's not terrible. I mean, basically what happens is you're going to ask a bunch of questions, you're going to get a bunch of no's, and then you're going to sort of say, you know, okay, here's my brief advice, and you're going to move on. I think that the major issue there is that you're taking more time to do it. And so it's just a question of how long visits are and how much time you really want to devote to talking about drugs versus other things.
Okay. And the next question is SBIRT with adolescents considered to be an evidence-based program/practice?
Oh, thank you for asking that question. It's something that I did want to bring up, so thank you for giving me the opportunity to do so. The United States Preventive Services Task Force has looked at screening and brief interventions to reduce alcohol use in adolescents, and they released a statement fairly recently, said that there was not enough information, not enough research has been done to draw conclusions on whether this practice is effective. Now, that having been said, there has been some research, most of it not done in primary care, most of it done in emergency rooms and other settings, but using exactly these kinds of brief interventions that look really quite promising. And so, although the evidence base is not yet sufficient, and I should also say that the USPSTF has not identified any risks to using these types of brief motivational interventions with adolescents. So with all of that in mind, the American Academy of Pediatrics has stated as a matter of policy that we recommend screening and brief intervention as a part of routine health care for all adolescent patients. Even though there's some more work to be done on efficacy, we don't really have the evidence base to prove that there's efficacy. There's enough evidence. There's enough suggestive evidence. There's a lot of evidence with adults. There's enough suggestive evidence with adolescents. There's no risk of harm, and the interventions are really, quick and easy to do. The major cost is time, but because they're so quick, it ends up being, a relatively minor burden. So the American Academy of Pediatrics now recommends it, as does the NIAAA, who has put out the Youth Alcohol Screening Guide, which I have showed you. And more recently, I think, in fact, this week, we put out a continuing medical education course through Medscape, which is demonstrating how to use that tool with subsequent brief interventions, a lot like the cases that you saw here, but different cases with different outcomes, to teach people how to use that tool, and that's available on Medscape as of today.
Okay, and then we have another question. If you recommend the youth come back after a brief intervention, would you see there being any downside to suggesting they return sooner than 1 to 2 months?
No, I would say that if you can get them to return sooner, that's fabulous. I think kids who have high-risk substance use, if you can keep tabs on them, that they will do better. We put in there 1 month or 2 months because we, just as a matter of practicality, we think it's hard to get patients back more frequently than that. But, absolutely, if your practice can encourage that, absolutely.
Okay. Do you ever ask the pros and cons questions re their AOD use?
So, that's a good question. So, for people who may not be familiar, pros and cons is a standard tool that's used in motivational interviewing counseling. And I think it's a very good tool. I think people can use it really very successfully. And again, I think that there's nothing wrong with it at all. We have developed brief motivational interventions that really don't need a lot, that can be done very quickly and really don't need a lot of tools because they're being done in the course of some other type of visit. And so that's why they're really pretty bare bones. But if you, if you can introduce a longer version of this where you use some other tools and really get them to spell out the pros and cons even better, I think that's great. That's really essentially what the assessment is trying to do. It's just trying to do it very quickly.
Okay, and let me see if there are other questions for you. All right, I do have one. Where could I find funding to implement SBIRT?
So I actually might turn to some of the organizers of this webinar to help with that question.
Okay.
So, the one thing I could say is that I know that SAMHSA has, in the past, given lots of grants to different states to provide SBIRT services and to do SBIRT training for clinicians. Those are done through cooperative arrangements. If you're talking about an individual practice, there are billing codes that can be used both for screening and for brief intervention. I have to limit my comments on this because I'm not an expert on that topic, but if you're interested in figuring out how you can bill for those services provided, the American Academy of Pediatrics does provide some guidance on that for physician visits, and I believe there are other resources for mental health visits as well.
This is Chris. Sorry, my phone was acting up earlier, so I had to get off and start over. And again, we could ask for anybody higher up who can answer this question to chime in, please. But I know that you're right, there are codes where you can bill Medicare for SBIRT services. They have to be turned on in your state in order to do that, though. And so I would suggest, like you mentioned, check with that organization or check with your state to see if you would be able to bill for the SBIRT codes. Some states do require specific training in order for you to do that, though. So I would check with the state on that. Okay, I don't see any other questions here, and I will, in the email I send out to all attendees tomorrow, I can include information on where they can find information about billing for the SBIRT services, at least contacts within their state to do that. Now, you want to talk again because it doesn't sound like anything's happening here.
Are there any other questions that the audience would like to ask?
Okay, Dr. Levy, I think that takes care of it. I will take the screen back if you don't mind. Thank you so much. This was very, very helpful. Are you still there?
I am still here.
Okay, good. Thank you. It was so quiet. I wasn't sure if my phone was breaking down again or not. So I really do appreciate you being on this. It was so much information. I know everybody's going to want to go back to review this webinar again afterwards. It will be shown in our webinar library tomorrow. I will have that up and send everybody the link to that. And your slides will be on there too. I've had a lot of requests for your slides. So there's so much information. I personally even found it very interesting, and I'm not really in this field, so I really, really appreciate your information.
Wonderful. Thank you.
Sure. Thank you. Now, I have this slide up now showing 2 other webinars we have going on this month. We are co-presenting these 2, and you can go onto our website to read more about these 2 upcoming webinars. One's tomorrow, and you can register through that link as well. So at this time, I will sign everybody off. In about 2 hours, you will get an email asking you to complete a short evaluation of this, and I hope everybody will do that. And then tomorrow morning, I will send you the CEU information, your certificate of attendance, and the links to see this all online. So thank you very much.